All right, well, good afternoon, everybody. First of all, thank you to the Department of Surgery for putting on this wonderful conference and for the opportunity to share our work with you today. My name is Jason Guo. I'm a postdoc in the Longacre Lab here at Stanford Surgery. And today I'm going to be telling you about our project to study the impact of tumor spatial organization on patient outcomes in the context of pancreatic cancer. I'd like to start by touching upon the clinical relevance that motivates our project. PDAC, or pancreatic ductal adenocarcinoma, is one of the most lethal cancers and is projected, in fact, to become the second leading cause of death in the context of cancer within this next decade. Now, it presents a terrible survival rate, and it's also uniquely characterized, along with other solid tumors, by extensive scarring or fibrotic tissue, which we refer to as desmoplasia, both within and around the tumor space. And so the question that we wanted to ask was, what is the impact of the spatial organization of that fibrosis, that is the fibrotic architecture, on patient outcomes? So to answer this question, we pursued this analysis in three distinct stages. Our first step was to quantify the actual fibrotic architectures that we observed within PDAC. The second was to analyze complementarily the organization of cells within this desmoplastic space. And then finally, we took these two modalities and we unified them using machine learning models in order to generate prognostic signatures for patient outcomes. So I'd like to start by talking about the first stage of this project, which was to quantify fibrotic matrix architecture. So our lab has previously developed an algorithm for the analysis of matrix architecture in fibrotic diseases. And the way that this works is that you can take your patient specimens, stain them using a number of standard histological stains, and then from that use color deconvolution to pull out the color channel that essentially represents the actual matrix staining. Now, from that matrix staining, we can then identify the underlying digital fiber map, which we can use to quantify a series of different parameters that tell you comprehensively what does the architecture of fibrosis looks like. So that includes a collection of local fiber properties like fiber width and length, as well as higher order features like fiber branching, fiber porosity, etc. And so it really gives you this sort of collective portrait of what your fibrospatial organization looks like. So we took this algorithm and we applied it to over 400 PDAC patients and over 13,000 histological images stained using trichrome in order to analyze the distinct and overall matrix architectures you observe. And so what we found was that these data points on the left represent the overall architectures presented by patient histological specimens. So points that are closer together are more similar in architecture, and points that are further apart are more distinct in architecture. And what we found is that broadly across all these patients, they exhibited two global architectures. And why is that important? Well, it turns out when we integrate the clinical data into this analysis, what architecture you exhibit on average actually is predictive of patient survival. And turns out that having an architecture on the right-hand side of that manifold, as opposed to the left-hand side, predicts survival that is worse by over 600 days in median. So that indicates to us that fibrotic matrix architecture has a huge clinical and prognostic impact. And we looked at a set of other parameters within our clinical metadata to get a sense for how predictive this was independently. And we actually found no significant differences between a number of standard clinical metadata categories, including age, sex, even tumor size, between the left and right side of the manifold, indicating that matrix architecture was the strongest predictor of patient outcomes. Given the importance of matrix architecture, we sought to analyze the complementary organization of cells within the stromal space. So in order to do that, we applied a technology known as Codex. The way that Codex works is that you take this multiplexed antibody-based panel and you use it to quantify the expression of proteins at individual locations within your tumor specimen or your tumor slice. And then using those profiles of protein expression, you can actually identify cell types. So we took a lot of inspiration from single-cell RNA sequencing techniques in which you can take gene expression to identify cell types. And we did something similar with Codex by taking protein expression profiles, identifying cell types, and then directly mapping them onto those spatial locations within the tumor specimen itself. So if you look at the right-hand plots, you see that we found a couple different cell subpopulations, and then we mapped them right onto the tumor specimen to see where they're located relative to each other. And furthermore, you can correlate the presence of specific cell types as well as cell spatial organization to differences in patient outcome, that is survival, disease-free recurrence, etc. And it turns out that having certain subsets of activated and highly inflammatory cell types, including subtypes of B cells and tumor cells that express large amounts of IL-6 or PD-L1, tend to be predictive of worse outcomes. Furthermore, we can assess what are the specific cell-cell interactions, that is cell types being close to each other, that indicate worse or better outcomes. So this is essentially telling you how the actual spatial organization of these cell types, not merely their presence, can be predictive of patient outcomes. And what we found was that certain interactions are survival positive. For instance, having a cytotoxic T cell next to a pericyte, which implies cytotoxic T cell invasion, was a highly survival positive interaction. On the other hand, being adjacent to really any of these highly activated inflammatory cell types was predictive of worse survival for our patients. And we were also able to assess how cell spatial organization changes on average for patients who did and did not receive neoadjuvant chemotherapy, for larger tumors, et cetera, by correlating these parameters with various clinical metadata that we had access to. But one of the most critical analyses I want to point out here was looking at how the matrix architecture is correlated with these differences in cell spatial organization. So we found that the outcome positive matrix architecture, that is ECM type L, was associated with a number of macrophage-driven interactions. On the other hand, survival negative architecture was associated with a number of pro-inflammatory fibroblast interactions. So to us, this indicates that fibroblast heterogeneity may play a critical role in driving differences in matrix architecture. So we had all this data related to matrix architecture and cell spatial organization. We want to take all this information, all these different features of the spatial organization, and combine them using machine learning to generate prognostic models. So we took this feature set, which has a couple hundred different parameters, including architecture, cell interactions, and clinical metadata, and we used standard techniques of feature selection to reduce the feature set size down. We did this because when you have so many features, you run the risk of overfitting your models and finding patterns in noise rather than in genuine clinical variation. So we used these standard techniques such as sequential feature selection to identify a smaller but more highly predictive feature set. And then using these features, we can train a number of typical machine learning models to achieve AUCs over 0.9, which at this point simply means that the models have fit onto the data set itself. But the ultimate test of efficacy or accuracy for a machine learning model is how well it performs on an external data set that was not part of model training. So we took 40 patients that were not part of the analysis or the model trained to begin with. We characterized them using codex, and then we took their protein expression profiles and we fitted it by anchor transfer to the previous manifold in order to predict the cell types and their spatial locations within these new patient specimens. And then using this, we could run the data through the same standard processing pipeline to generate an analogous set of features. And we ran these features to the machine learning models, which again have not seen these patients or their data. And there we were able to predict patient outcomes and to stratify them with AUCs of about 0.9, essentially accuracy of about 90%. And to us, this was a very significant result, especially given that when we looked at median differences in terms of the patients that were stratified into one risk bucket versus another by these prognostic models, they separated out patients by nearly over 600 days, nearly 2 years in terms of median survival. And this is a remarkable finding for a disease that has a 5-year survival rate of only about 10%. It's very significant stratification in terms of patient survival and outcomes. Now you may ask, what are these specific parameters that actually drive predictions, right? What is going on inside the machine learning model? And so we performed an explanatory analysis in which we looked at the specific parameters that are actually driving predictions made by the model. And we found that the most predictive parameter was tumor grade, followed in a very close second by matrix architecture. There was additional predictive support provided by more granular parameters, including individual matrix properties and cell interactions. But really, this underscores to us that matrix architecture really matters and plays a big impact in generating prognostic value. So the overall conclusions from our study were that we found this specific disrupted and sheet-like matrix architecture that was associated with worse patient survival and disease recurrence. Then next, by analyzing cell spatial organization, we found an axis of inflammatory cell interactions that drove worse survival. And that finally, we're able to create unified machine learning models that pulled in all this data and then predicted patient survival in an independent cohort by nearly 2 years. So all this brings home this one take-home message, which is that desmoplasia is really important, matrix architecture matters, and these things have real prognostic value. And we have filed IP on this technology as well. So I'd like to conclude by thanking all of the lab members who contributed to this project, to our funding sources, and thank you all for your attention.
Hello everyone, my name is Liming from the Chan lab. Today my presentation is about the rescue of ischemic disease by transplanting intact vessel stem cell niche cell clusters. So it's pretty well known that the vessels are critical for development and also regeneration, and the loss of blood supply could lead to ischemic disease. However, the stem cells responsible for vessel formation is still not clear. So when I joined the lab, I focused on identifying the vascular stem and progenitor cells and utilizing those cells for vessel regeneration. Here we use the mouse model called rainbow reporter mouse. In this mouse, all the cells carry 4 types of different fluorescent proteins. But before the induction, they will just express one of the protein, which is GFP, all the cells will be green. After the tamoxifen-induced recombination, one of those 4 proteins will express, and all the daughter cells will carry the same color of proteins. So imagine if there is stem cells keep proliferating for a while, there will be more and more cells carrying the same color, which is called colonal formation. So to identify the vascular stem cells, we induced a vessel injury model by liking the femoral artery of the rainbow mouse. After the ligation, there will be some cells proliferating, which is trying to regenerate the vessels. So in the injured mouse, we can see more clones, and the cell numbers in each clone will be more than the control group. So we collect those tissue for single-cell sequencing to identify the markers for those cells. And in combine those markers, and we can isolate the cells for transplantation to see if they can really form vessels in vivo. So here we found 2 populations can form vessels in vivo, which is PDGF receptor alpha positive and type 2 positive population, and the CD31 positive and the type 2 positive population. So in combine with those populations, these markers, we further define the cell surface marker for the vascular stem and progenitor cells by CD45, type 2, PDGF receptor alpha, and CD31. So in the combination setting, we can see the vascular stem and stem progenitor cells population 1 can form small vessels on the left side, and the VSPC2 can form both vessels and fat in the transplantation setting. Interestingly, if we combine the VSPC1 and VSPC2 together, then transplant those cells into the mouse, all the cells will form good vessels, and they can carry blood. Those cells are also surrounded by parasites, which means those cells are really functional and connected to the vascular system. Further, we isolated those cells, VSPC1, VSPC2, and the combination with VSPC1 and VSPC2 to compare if they can rescue the heterolymph ischemia model of the mouse. And in the figure, we can see the combination can rescue the heterolymph ischemia model faster and better than the single VSPC1 or VSPC2. We negated the left side of the leg, where we can see do the blood flow at the very beginning. Then over time, they can be rescued, which is shown by the red blood flow. So as we observed that the combination is critical, so we thought there might be some signals between the VSPC1 and VSPC2 are critical for the vessel formation. So from the single cell data, we can identify the single ligands and single receptors. Here we identified a group of signals, and we would like to highlight the PDGF signals, where the VSPC1 highly expresses the ligand and the VSPC2 highly expresses the receptors. If we block the PDGF signal between the VSPC1 and VSPC2, we'll see those combinations won't work anymore. So similarly, we identified these 2 populations from the human tissue, and we show that they can rescue the blood ischemic blood nodes from the mouse model. To summarize this part, we identified the VSPC1 and VSPC2 from the mouse and human, and the combination of these 2 populations are critical for functional vessel formations, which remind us the concept of stem cells and their supporting niche cells. So we wonder if the intact vessel stem cells and the niche cell clusters could lead to even better neovascularization. So here we used a microfluidic-based sorter, which can help us sort those larger clusters, and the sorting process is very gentle. So with this sorter, we can isolate specific clusters from the dissociated cells, and we compare the clusters, vessel stem cell clusters, and dissociated cells in transplantation setting. So after transplantation, we can see the clusters could form more vessels and carry more blood. So here's a short video to show the newborn vessels carrying blood and to rescue the ischemic. So here's a blood flow monitor over time after the transplantation of the dissociated cells and single cells, and the clusters. We can see the clusters can rescue the blood flow faster than the dissociated cells, and we also checked the related tissue which could respond to the ischemic disease, which is the distal femur bone structure. So in the cluster transplanted groups, they can prevent the bone loss from the ischemia. So to summarize, we identified the VSPC vessel stem, vascular stem, and progenitor cells, and we showed that the intact cluster of those stem cells and their niche cells could lead to better regeneration of the vessels, restoration of blood flow, and the rescue of ischemic disease. So we are also collaborating with our colleagues in the department to characterize those nations in different conditions, like after surgery or after irradiation. For the future direction, we are developing the synthetic and transplantable VSPC niche cell ulites. We want to utilize those as a bioglue to stimulate the vessel for regeneration and wound healing. I'd like to thank my mentors and our lab mates and our funding source for this project. Thank you.
Good afternoon, everyone. Thank you so much for providing this opportunity. And thank you so much for all the committee members for providing me this opportunity for showing my research presentations. So today my talk is related to the blood-brain barrier directed immuno-nano-conjugates. So everyone knows about the immunotherapy, what is that? But for the brain disease, especially, it is very, very important because brain is very important organ of our body. And if we have something in the brain that is very difficult, like Alzheimer disease or brain cancer or any kind of cancer. So as everyone knows, this cancer is very, very important for the like if this cancer is very, very dangerous, and if it is metastatic, so that is very difficult situations. So for that, like my work is related to the melanoma brain metastasis, because in my lab I'm working on the melanoma brain metastatic cancer. So my target is to deliver the drug towards the blood brain barrier, because blood brain barrier, it is very, very important. And if we can see here, there are very few molecules which can cross the blood brain barrier, some important molecules which is required for the nutrition for the brain. But like there are other therapies for the cancers which cannot cross the blood brain barrier. Either it will be a big molecules like genes or immunotherapies. So as everyone knows, like the CNS metastasis, like in 70% of the melanoma metastasis is occurs. And if it is metastasis, it is difficult to treat. So there are different like carrier system people are working on, like microbubble technology and nanobubble technology. But these are physical techniques which can cross the blood-brain barrier and deliver the drug. But the another important thing is the brain tumor microenvironment, which itself cannot cross the blood-brain barrier, because it's acting as like a security guard. Hey, don't cross these barriers because I'm a protector of the brain. So that is very, very important. So we need a specific carrier system to target the blood-brain barrier, and in that way we can treat the metastatic tumor. So the another is like the tumor protecting environment also. They are suppressing the macrophage, fibroblast, microglial cells, and fewer T cells also, because these immune cells, they want to release the cytokines on the local sites where the cancer happens. So they are decreasing the tumor burden. But due to the tumor microenvironment itself, it's difficult to cross the blood-brain barrier, or either they are exhausted in the environment. So for that purpose, like there are several therapies like immune checkpoint inhibitors like PD-1, PD-L1 directed therapies, CTLA-4 and NK cell therapies, and other. There are several. So antibodies is one of the important approach, the combination therapy. But again, these are big molecules and it is difficult. There are large molecular weight like 150 kilodalton, so they are difficult to cross the blood itself. We can use as a local therapy, but for the targeting to the brain, it's difficult to cross. So that's why this is very, very important. So here we choose a small peptides, which is like 2.4 kilodaltons, which is very, very small to cross the blood-brain barrier. And itself, these antibodies having toxicity issues, because these are bigger molecules staying in the blood for the longer time and causes several immune adverse events. So there is like 50 to 60% of grade tumors and off-targeted toxicity also, and the size also, as I mentioned. So for that purpose, like I synthesize this nano-conjugates which can cross the blood-brain barrier. So itself, this nano-conjugates is having these anti-PD-1 small peptides, which and the another peptides which is highly expressed on the blood-brain barrier, LRP1 receptor targeted peptide AP2, that is very very important to cross the blood-brain barrier. So for that, further after cell synthesis, we characterize this nano-conjugates, and further we characterize whether really it is crossing the BBB or not. So like, and for the animal studies and before the doing the human studies, so we are developing a human-based brain on chip model. So if you can see in the picture, this is we developed the brain endothelial cells, we coated the brain endothelial cells on the chip, and on the downside we created a 3D tumor spheroids. So here we want to see whether our drug is crossing the BBB or not, and if it is crossing the BBB, whether they are targeting to the tumor region or not. So first we check the blood-brain barrier penetration, and if you can see, the red one is my nanoparticles which is crossing the BBB actively. So after that we perform the tumor uptake also in this BBB devices. So this is the 3D spheroids. So if you can see the blood, these nano-conjugates, after crossing the BBB, they are crossing, going to uptake in the tumor environment itself in the red color. And further we check like whether, because these are checkpoint inhibitory small peptides, so whether they are activating the T cells or not, and whether they are interacting with the T cells and or not. So here we determine the binding affinity on the T cells. So the green is the CFSE labeled T cells, and the red is our nanoparticles, and the third image is the merging. So in case of activated T cells, this BBB targeted nanoconjugates is binding with the immune cells. So after determining the immune cells binding, so we want to see whether these immune cells are going to the the brain environment or not, and whether they are going to uptake to the tumor spheroids or not. Because if they are activated, so they should go to the tumor environment, and their job is to release the cytokines and the killing the tumor burden. So we check the tumor uptake here. After that, we performed the flow cytometry based analysis. So over that, we showed like in as compared to the PD-1 antibody and the free peptides, our nanoconjugate is proliferating the T cells, CD8 T cells, and the CD4 T cells. So further, we perform the Treg analysis, but here we don't get the particular Treg analysis results. So here we showed like CD4, CD8 is proliferated. So further, we analyze the cytokine expression in the supernatant also, and these interleukin-2, TNF-alpha, and the IFN gamma is highly expressed by activating the T cells. And in case of nanoconjugates, they are releasing the cytokines, which is very very important for killing assay. Further, because for the animal study, we want to see whether in the animals they are crossing the BBB or not, and how effectively it is. So we perform the AP2 targeted nanoconjugate biodistribution analysis, and in the image, if you can see, it's in the ex vivo distribution and the in vivo distribution, it is crossing the BBB and going to the uptake in the brain. So this is like really really important. So if we have that kind of conjugates which can cross the blood-brain barrier and available in the brain tumor environment. So further, our current and future aim is to we want to determine this nanoconjugates, the in vivo efficacy study. And then after determining the efficacy, so there are some therapies also there are which is resistance to the chemo resistance, the checkpoint inhibitor therapy. So here we are targeting the AXL targeted therapy also. Why it is important? Because AXL is also like active responsible. If we are down regulating the AXL and gas6 expression, so we can increase the immune cells populations and the activation also, like macrophage, we can activate the M1 macrophage, and we can down regulate the M2 macrophages. So for that purpose, like in some cases where checkpoint inhibitors is resistant, so we can use the combination therapy also in the future. So for that purpose, we check the AXL expression in the stage 4 melanoma patient with anti-PD-1 therapy. So there are some non-responder, and if you can see the responder curve also. And further, we perform the AXL expression in the non-malignant cells in the melanoma tumors also. And this is like good correlation between the combination therapy. So in case of PD-1 resistant tumor. So further, we perform the PD-1 resistant, we prepared a PD-1 resistant model also by using GM cells. And if you can see the tumor burden, so the in vivo efficacy of this combination therapy is highly effective, and the tumor volume is going to be down. So in conclusion, we prepared this nanoparticles which can cross the blood-brain barrier through receptor-mediated uptake and improve the delivery of these small peptides. And further, we are using like we identified AXL is very important target that present a rational combination strategy in second generation bispecific nanoconjugates for time reprogramming. So I would like to say thanks and acknowledge to Dr. Amanda Kirane and my Stanford team members and my previous members from Dr. Ali Khadim Hussaini Terasaki Laboratory. Thank you so much, everyone.
Good afternoon, everyone. My name is Khristian E. I'm an MD PhD student in the Longacre and Hume Labs, and I'm thankful for the privilege to be able to present our research looking at the role of creeping fat in intestinal stricture formation. So Crohn's disease is a subtype of inflammatory bowel disease, which is characterized by transmural patchy inflammation that can occur anywhere in the digestive tract. And one of the most significant complications of this illness is the formation of an intestinal stricture. And strictures are a great example of a process that we know as fibrosis, whereby fibroblasts deposit excessive amounts of extracellular matrix, and as a result, normal tissue is replaced by scar tissue. And this ultimately results in organ dysfunction. And so what you're seeing here are two images of colonoscopies from normal bowel on the left and from strictured bowel on the right. And you can appreciate the presence of scar tissue, which is now occluding the bowel lumen in the strictured bowel on the right. And as a result, a lot of these patients present with issues of malabsorption and bowel obstruction. So stricture formation is a significant clinical problem. It's estimated that there are 3 million Crohn's disease patients in the United States alone. 50% of these patients will ultimately develop some sort of stricture or penetrating complication. And 80% of these patients will require surgery within 10 years of their diagnosis. And of these patients, it's estimated that 70% will have some sort of stricture recurrence. Interestingly enough, despite significant advances in anti-inflammatory therapies, stricture incidence remains relatively unchanged. And other than bowel resection, which isn't really a cure, there are no anti-fibrotic therapies. One of the most unusual phenomena associated with intestinal strictures is that of creeping fat. So that is the expansion of mesenteric adipose tissue around the diseased portion of the bowel. And so as you can see here on the intraoperative image on the left, taken here at Stanford, I believe these are Deshka's hands actually. You can appreciate the presence of fat that is surrounding the intestinal stricture. And what you're seeing in the middle are now cross sections of adjacent uninvolved bowel as well as the stricture. And you can appreciate the significant expansion of that mesenteric adipose tissue around the bowel. And if we stain for collagen, as seen on the right, you can appreciate that there's significant collagen deposition in the bowel wall that is adjacent to the presence of creeping fat. And so these observations beg the question, what is the role of creeping fat in intestinal fibrosis? Is it just simply a passive bystander that is a response to inflammation? Or does it play a more nefarious role in the formation of strictures? And so to answer this question, we took pediatric Crohn's disease strictures and then divided them into adjacent uninvolved bowel, as well as strictured bowel. We carefully dissected the mesenteric adipose tissue from the bowel. We dissociated them separately and then captured these cells and then performed single cell RNA sequencing, hoping to understand a little bit more about the fibroblast heterogeneity present in these samples. And so what you're seeing here on the left are the global clusters that we obtained from these samples. And you can appreciate that we've been able to identify the major cell types that we would expect in these samples. If we look at the fibroblasts that are present, we were able to identify 7 major subpopulations. But there was one population that stood out to us in particular, these PDGF delta positive cells, because they seem to expand in the mesenteric adipose tissue that is in the stricture. And you can appreciate that expansion in the UMAP on the right, that is those green clustered cells. And so we know that fibroblasts respond to mechanical cues in a variety of contexts, especially in response to stiffness. And so we hypothesized that there may be these stricture-associated fibroblasts that are actually mechanoresponsive. And so what we did was we looked at the gene expression of these mechanosensitive genes, including PTK2 or FAK, YAP signaling, as well as downstream targets such as CTGF and CYR61. And what we were able to find was that in this PDGF delta positive population, that there was this upregulation of these mechanosensitive genes. If we perform gene ontology analysis, which kind of gives us a flavor for the differentially expressed genes that we're finding, we were able to identify some mechanosensation pathways that were present there. And then in a further bid to understand where these cells are located, we stained our stricture tissues for TIMP1, which also marks this mechanosensitive population. And what we found was that they're present in the creeping fat, as well as at that interface between the fat and the bowel. Of course, the disadvantage of single-cell RNA-seq is that it doesn't give us any spatial information. And so to overcome this, we performed spatial transcriptomics. And what we were able to do was we were able to take histology sections and then sequence the RNA in those sections to obtain a profile for the gene expression. And then what we did was we divided the section into different tissue domains, namely the area that contains creeping fat. In addition, we looked at the bowel wall, which is closer to the lumen, which is in the red, as you can see in the tissue domains. And then we also identified this very stromally rich area that was in between the creeping fat and the bowel, which we designated as the interface. And then from there, we performed cell chat, which is this algorithm that allows us to distinguish these ligand receptor interactions that may be occurring in these cells. And so very interestingly, when we do this division, we're able to find that there was an enrichment of these ECM genes, such as collagens and fibronectin, as well as fibroblast genes in the creeping fat, and particularly at the interface. And I just want to point out fibronectin in particular because it seems to localize very clearly to the interface. And that suggests that it's really the interface that may be the most actively involved in stricture formation. So next, we performed cell chat, as I mentioned before. And very interestingly, we see a number of interactions occurring between creeping fat as well as the interface, as you can appreciate on the left, as well as a very enriched number of interactions that are occurring within the interface itself. And then finally, what we were able to do was extract some of those pathways. And what we found was that a lot of them are mechanically driven, including collagens, fibronectin, as mentioned previously. And so this suggests that we have some mechanosensation pathways that are being activated, in particular at the creeping fat bowel wall interface. And so in conclusion, I hope I've been able to show you that we have identified a mechanosensitive fibroblast population that is present in human strictures that localizes to both creeping fat and the interface. And in addition, I hope I've been able to convince you, at least by spatial transcriptomics, that it appears that the interface between the creeping fat and the bowel wall appears to be a significant player in the formation of intestinal strictures. And so our future directions include being able to take the spatial transcriptomics and be able to deconvolve it in such a way where we can get single cell resolution, because at the moment, one of the major limitations of spatial transcriptomics is that inability to get subspot resolution. And what we'd like to do as well is utilize a mouse model that we have of intestinal strictures to be able to understand what is the role of mechanics and tissue stiffness on the formation of these intestinal strictures. And so with that, I'd like to thank Dr. Hune and Dr. Longacre for their unwavering support of this project. For Alexia in particular, who has done a lot of the heavy lifting that you're seeing, and seeing some of her results here. For all of the Longacre and Hune lab members, my funding sources, my thesis committee, and I'm happy to take any questions.
First, thanks for the opportunity to be here. I'm meeting Wang from Chuck's lab, current postdoc in a Stanford Stem Cell Institute. So today I'm going to introduce a new approach for single-cell spatial transcriptomic analysis in stem cell niche. So first, what are the stem cell niche made of? So supposing this blue cell is stem cell, then the stem cell niche would be made of with all these different type of cells around it. Since our lab identified mouse skeletal stem cell and its downstream lineage 2015, we are trying to understand the crosstalk within skeletal stem cell niche and use it for clinical treatment for example, the articular cartilage regeneration for the osteoarthritis patient, and the callus formation for the ununion patient. And in our previous studies, like I already mentioned, we have shown that by modifying the stem cell niche with key factors, we can reactivate the residue stem cell both for cartilage regeneration and bone rejuvenation. Hence, we are trying to recreate a regenerative surrogate niche with CRISPR engineered cells that can mimic the signaling signal stem cell received from its niche cells. So to achieve this goal, it's very important to understand what, when, and where are the signals delivered in a stem cell niche with a single cell resolution. However, with current single cell sequencing techniques, the data we get is mainly like this. They're overlapping together. We don't know who deliver factor first and who is the responding cells. So yeah. So we are trying to do the spatial transcriptomics to understand who is doing what. But however, as we know that there are various approaches for spatial transcriptomics, as mentioned in previous speech. However, none of them is perfect for us for our purpose. While they can give us a gross spatial map of expression gene in the tissue we are interested in, we have either to sacrifice the single cell resolution or high gene coverage during the sequencing. Hence, we decide to develop our own approach to understand the crosstalk with stem cell niche, and we name it Tesseract, short for temporal spatial single cell transcriptomics. So here is the brief idea of Tesseract. We are using a fluidic-based on-chip sorter to enrich intact cluster containing stem cell. And with the rainbow system, also give us a chance to barcode each cell in a cluster with different combination of fluorophore. And we can use the confocal to record the spatial information of each cell in a cluster, and index sort for SMART6 single cell sequencing. Since both data from confocal and the FACS is based on fluorophore intensity of each cells, we can try to, by matching the FACS events back to the cell in confocal, we can pass on the spatial information from the confocal image to the single cell data and understand what exactly each cell is expressing within that cluster or the stem cell niche. And at the same time, we also find a way to quantify both the size and the fluorescence of each cells in a Z-stack image with an algorithm based on cell pulse neural network, which was published recently. To match the FACS event to cell, events to cell in a confocal image. So the first step we did is generate the matrix with fluorophore intensity of each cell for both confocal and effects, and scaling them to same level for next step match. And since with each of the data from confocal and effects give us the matrix based on all the colors from rainbow and also the size of the cell, we can measure the distance of the two events from either confocal and effects to see if they are if they are close. For example, if they match, then when you comparing these two matrix, the distance between these two events will be short. Then you say you can calculate the probability of these two data coming from same cells, and so we generate a match algorithm to provide each event in the fact data set with a list of top 20 match from the confocal data set together with the predicted probability of each match. So if the probability of one match is close to 100% and the rest of the match probability is close to 0, then the match is considered to be a real match. So now let's get back to where we started. Since we have shown growth plate is one of the regions that are reaching skeletal stem cell niche, we decide to start with this type of tissue and test our tesseract analysis. And since the growth plate cartilage always form a column-shaped colony in the long-term lineage tracing. So we isolate the cluster from this area and apply them with tesseract analysis. So here we show the we show a confocal image of the cluster we isolated from the rainbow mask growth plate, and here we show the heat map of this cluster generated from our single-cell seq data with cell ID from confocal image at the top and the gene name on the side, and also locate each cell in the cluster with the gene they are expressing and the markers they are expressing. And here is the single-cell data we get from the smart-seq, and we see even within this small cluster, each cell is still not that homogeneous; it's still heterogeneous. Like they are expressing different genes within different population, and we also checked the cytokines that's differently expressed in each population, and we find the Indian hedgehog is also in it, and we take a look at the receptor and the receptors and its downstream gene in the cluster. We find that this one is the receptor response for saturating Indian hedgehog. You can see the receptor and the Indian hedgehog is highly expressed in one population. However, the receptor to take the hedgehog and the downstream, the receptor to take the hedgehog, which is the patch 1, and the downstream gene under the Indian hedgehog signaling. For example, the BCL2 is actually upregulated in another group of in another group of population, indicating the cell expressing Indian hedgehog is actually not the one take it. Is secreting for another population of cells to take it. So it's like regulating within the skeletal stem cell niche. And in summary, tesseract is a new approach for exploring the true stem cell niche at the single cell level in 4D if you take the cluster from different time, and with higher, of course, with higher gene coverage and the full-length sequencing with the smart-seq platform, and it's also suitable for other plate-based methods like single-cell ATAC-seq and single-cell proteomic analysis. Anything based on sorting to plate, you can use it since it's already in the plate for each cell. And of course, tesseract also have its limitation. So first, the dissolution protocol need to be optimized for each type of tissue. We already optimized for bone, cartilage, intestinal crypt, and the vessels, and also marrow tissue. But however, for other tissue, since you need to dissociate a small cluster into single cell, That's a little bit from bulk tissue, so you need to optimize it a little bit. And currently, we are using the optimal barcode from rainbow tissue. Which means if you want to doing it on human tissue, human is not rainbow, right? So we are trying to developing antibody-based barcoding system. So you can using the antibody to staining the non-fluorescent tissue, like human or other animals. Then you can also use tesseract for those tissue and analyze it with smart-seq data to get the spatial information within the niche. So before end of my presentation, I'd like to thank the strong support from our team, especially from Dr. Chen and Keding, and who is responsible to generate an algorithm for matching, and also Yan Soko, who is responsible for doing the quantification from the confocal image, and also Tom Ambrosi help us doing the single cell data analysis, and all our funding resource. Thank you.
Thank you so much for the introduction and the department and organizing committee for the opportunity to present our work today. As you know, open repair of thoracoabdominal pathology remains a gold standard treatment for this type of disease process. Unfortunately, it's plagued by high risk of perioperative mortality and morbidity, despite recent increases or improvements in perioperative management and operative techniques. In the last decade or so, the advent of fenestrated and branch technology has significantly revolutionized the treatment of complex aortic disease, and in particular has enabled us to obtain more proximal seal and preserve renal visceral branch perfusion, and this has significantly improved overall length of stay and perioperative mortality. As you can imagine, that the advent of these and uptake of these devices has significantly increased in the past decade. Across not only in the US, but at Stanford as well in our division. However, the Achilles heel of these approaches remains limited by the durability of the branches to the visceral and renal vessels themselves. And some studies by people in our lab as well have demonstrated nearly 20% risk of branch-related reintervention, the most acute of which is branch vessel occlusion, which results in significant patient morbidity and mortality. Lots of times these stents occlude based on structural problems with the stent, compression, kinking, but a lot of times we see they occlude without any visualized abnormalities on their cross-sectional imaging, and this is very frustrating from a clinician's point of view because you can't really predict which patients will present with this problem. And here's a couple examples of fenestrated and branch repair where you can see an occluded right renal stent on the left and then occluded celiac stent where there's no issues foreseen on their postoperative CAT scans. We thought to ourselves, could this be potentially some issue with the underlying flow turbulence or flow stagnation that could be a cause of these issues? And so we thought this is a good application for potentially applying cappuccino fluid dynamics, which a lot of people are familiar with this in this room. It's been developed traditionally in aerodynamic engineering, has largely supplanted more expensive wind tunnel testing for improving aerodynamic performance of certain devices, aircraft, transportation. In cardiovascular research world, this would be analogous to replacing expensive phantom model in vitro testing to in silico testing using virtual computational simulation. I've been fortunate to be mentored by Dr. Allison Marsden in bioengineering, applying some of these novel techniques here for the first time, studying patients that have been repaired with complex EVAR and have even found some correlation to thrombotic events after simple fenestrated repair. And this is an overview of our overall CFS or computational flow simulation framework, where we apply preoperative and postoperative CAT scans. We segment out the vessels, create 3D models from which we can then apply patient-specific boundary conditions. We scale pulsatile inflow waveform based on patient allometrics, including body surface area. The outlet boundaries are then tuned to match patient's heart rate and blood pressure. These then serve as the basis for our flow simulations from which we can computationally estimate perfusion performance. We can graph out a flow and pressure waveform on each of the branches, as well as assess near wall hemodynamics such as wall shear stress and particle residence time. Our central hypothesis was that we would be able to predict potential adverse outcomes based on potential adverse or abnormal hemodynamic variables, specifically at branches that didn't have any associated abnormalities on their CAT scan imaging. So this is a multi-institution retrospective cohort study. We utilized patients from a large investigational device database by our colleagues at UT Houston and Mayo Clinic, who has the largest database of these advanced repairs in the country. There's a total of 36 target vessel branches. You can see here just a breakdown of occluded stents. There are 3 mesenteric stents, celiac and SMA occluded, and more commonly were found in the renal arteries, 7. We did a subgroup analysis based on stratified on mesenteric vessels and renal vessels, as those vascular beds share similar boundary conditions, and the patent branches within those served as internal controls. Here's our overall patient demographics. You can see that these patients in general, overall sicker patients, not candidates for open repair. We treated extent 2 through 4 thoracoabdominal aortic aneurysms with a maximum aneurysm size of over 6 centimeters. A couple case examples here. Patient treated for with an extent 4 thoracoabdominal aneurysm with a celiac branch occlusion. Here you can see computationally estimated flow and pressure waveforms demonstrating significant reduction from their postoperative values in the celiac stent. And then when we mapped out their wall shear stress along the stent, you can see in the distal aspect, the areas shown in red have a higher abnormal wall shear stress associated at that native stent interface. Here's another example of a renal artery, similarly decrease in estimated renal branch perfusion associated with some wall shear stress abnormalities in the distal stent. Unfortunately, when we looked at the overall perfusion metrics, specifically the branch pressure and flow rate, we did not find any significant hemodynamic differences either in the mesenteric or renal vessels associated with occlusion versus patent branches. However, interestingly, and this kind of is in line with some of the existing literature as well, based on in vitro testing, near wall hemodynamics like wall shears tend to portend worse outcomes than just branch changes in flow and pressure alone. And specifically in the renal arteries, we did find a statistically significant signal, which you can see more graphically laid out here on histogram. So you can see that patent branches had, in general, less than 10% total area of abnormal aortic or branch-related wall shear stress, whereas patients that had occlusive disease or future occlusion had greater than 10%. And this was borne out in our ROC analysis, where greater than 10% abnormal wall shear stress correctly classified over 90% of cases with an AUC of 0.9. When looking at our wall shear stress mapping, you can actually see qualitatively where the areas of abnormalities exist. And in general, across the renal branches, we found that most commonly these are visualized at that native stent and renal artery interface, which potentially could be a future target for differences in endograft configuration when we're actually designing the grafts preoperatively in clinic, or potentially endograft design. So in conclusion, although this is a small sample size study, this is one of the first studies to correlate patient-specific computationally estimated metrics to potential adverse events after complex EVAR. Specifically, we found that increased areas of computationally estimated abnormal wall shear stress can identify potential renal branches at future risk of occlusion. Lots of prospective studies and validatory studies are needed in order to see whether this has any future potential clinical utility. And I'd like to thank our funding sources and Dr. Jason Lee and Allison Marsden for their ongoing mentorship over the last decade now, it seems like. And just a quick note on what we imagine our future clinical application for this type of research and potential clinical adoption, where you see a patient in our clinic. Right now, they get anatomically sized, but not necessarily hemodynamically optimized grafts. We foresee potentially a clinical tool that can play a part in that decision-making and surgical planning process. Postoperatively, we can use similar techniques to stratify their postoperative risk, and eventually kind of transition from just custom anatomy-focused EVAR strategies to really personalized EVAR and hopefully improve patient outcomes. Thank you, and happy to take any questions.
Good afternoon. I'm Siavash. I'm a postdoc at Dr. James Dunn Lab in Pediatric Surgery. Today, I want to share with you our recent advances in our enteroid project using next-generation surrogate twins and R-Spondin. The focus of our lab is to find treatments for children with short bowel syndrome Here are some statistics that can show how poor the quality of life of these patients is and the burden of healthcare costs. I just want to mention that 5-year mortality rate of these patients are 55% in the US, and it has been increased 55% over the past decades. Enteroids are prefabricated structures derived from epithelium, and the reason that we don't call them intestinal organoid is that they don't contain a stroma and the muscle cells. For the first time, we reported the successful transplantation of enteroids to intestinal lumen. For that, we de-epithelialized small intestine and transplanted enteroids to the lumen. And after 4 weeks, we detected regrowth of epithelium with expressing functional differentiated cells. Wnt is a growth factor essential for embryonic development, tissue regeneration, stem cell differentiation, and it's been widely used in organoid research. So far, there are 3 resources for Wnt that has been commonly used. One of them is water insoluble. The other one contains non-well-defined components, and the last one can activate lots of off-target pathways. Next generation surrogate Wnt, NGS Wnt, is a product of Dr. Garcia lab at Stanford Structural Biology Department, which is water soluble. It can specifically bind to freezell subtypes of the receptor of NGS Wnt, and it can improve oligomerization between receptor and co-receptor of Wnt, which can result in more specific and more efficient activation of downstream pathways. We detected also more viability, expansion, and long-term maintenance of organoids treated with NGS Wnt. R-Spondin is well known as a Wnt potentiator, and we could detect the synergistic effect of these 2 proteins in vitro on organoids, as well as in vivo, as we can see here that in the mice treated with adenoviruses expressing NGS Wnt with or without R-Spondin, we see more proliferation in this group. Also, we can see the significant increase in the crypt length in the groups that contains both R-Spondin and NGS Wnt. In the current research, we isolated enteroids from the mouse epithelium expressing red fluorescent. We cultured them in regular media for enteroids, and right before injection, we added PBS as control group or NGS Wnt or R-Spondin, and we injected subcutaneously to immunodeficient rats and collected the skin samples after 7 days. Here we can see the detected enteroids in the rat skin, and in the plot, each dot is representative of each detected enteroids. In the NGS Wnt group, we can see more proliferation rate, and interestingly, in the R-Spondin group, we see extremely large enteroids. We hypothesize that probably due to high proliferation rate of enteroids treated with NGS Wnt, they did not have enough time to get larger. In conclusion, NGS Wnt induces enteroid proliferation and expansion, while R-Spondin only improves enteroid expansion. For future, we will study the co-treatment of these 2 proteins. We will transplant them to the small intestine. We will do spatial analysis to see the effect of surrounding stroma cells within the lumen, how it affects the enteroid and the epithelial growth in the lumen. And we are interested to incorporate the enteroid transplantation and mechanical tension force, as we previously see that co-treatment of intestinal organoid transplantation with our spring-mediated mechanical force can result in more mature epithelium and better contractility of muscle and activation of pathways responsible for digestive tract development. I would like to thank our great team, especially Khristian E for his great dedication to this research, and thank you for your attention.